My name is Dr. Anthony Inchi, clinical psychologist at the University of Cape Coast, Ghana, a lecturer and also a counselor. I would like to share with you some of the mental needs and issues in my country, Ghana, and then some of the experience I've gained in the certificate program of psychopharmacology. Most psychologists in Ghana practice in their academic institutions as well. Though, according to some report, in 2011, we had about 19 clinical psychologists, 0.08 per 100,000, 21 social workers, 0.09 per 100,000, and 4 occupational therapists, 0.02 per 100,000, working within Ghana's mental health system, delivery system. I believe this may not change so much since clinical psychologists and other psychologists do work mostly in the academic institutions. I have come to appreciate the wonderful, great job done by this RSP International Program. The classes I've attended have given me the opportunity to explore some of the challenges we face in our mental health system in Ghana. In some of the classes assignment projects that I have with my students, they indicated the urgent need of clinical psychologists in this field be able to prescribe the legal implication involved, and if given the privilege to prescribe because of the shortage of psychiatrists in Ghana. The use and management of psychotropic medications and integration into a psycho-biosocial model of care is well discussed and offers me new insight in my practice as a psychologist, clinical psychologist, and also an educator, a lecturer at the university. And it helps me to how to balance the treatment of patients with this model. Second, particular attention is focused on psychotropic drugs and effects on the brain, as well as current research presented. I say excellent, great job, and kudos. One relevant point is the objectivity of the speakers of their presentation. When to and not to prescribe these medications are well explained, while they emphasize the importance of medication in helping some disorders. They also rarely do affirm that students that not all mental disorders need to be treated with medication. Well, to me, it was a very good thing to hear that. Because most of the time, people think that every mental disorder should be treated with medication. This really made me feel very comfortable in working in this area as well. I've learned how to connect the mind and the spirit that we need it. The mind is here, the body, we need to integrate that genetically, biologically, and socially. Role plays in their presentation make it more meaningful. I have gained more confidence to communicate and work effectively with physicians in the future. The need to offer community services in mental health centers could be one of my areas I want to also offer as a way of pro bono to my Ghana community. I hope to be an advocate of task shifting due to few mental health personnel who prescribe medication in Ghana. And also I would like to develop a new way of teaching students. In this program, I'm offering substance abuse, neuropsychiatry, psychopharmacology. What I used to do was to treat them in isolation, But I think looking at the presentations I've already gone through, I'm going to really review my notes and maybe integrate that. It makes it more meaningful than what I did. I would like to thank all of you, and I'm so much motivated and excited to enjoy and also to enroll in this program of psychopharmacology. Thank you.
Hi everyone, my name is Sinchita V. Bhattacharya. I'm a practicing psychologist from New Delhi, India. I would first like to extend my deep gratitude to my professors, Dr. Ellen Levine and Dr. Ellen Foster, for giving me this great opportunity to voice the urgent need for Indian psychologists in this APA forum today. Yes, we need to gain that additional knowledge of psychopharmacology and psychobiosocial model of care to assist in the treatment of mental illness. Like many other countries, India too has a top-down treatment for mental health issues or problems. As in other countries, here too there is a clear-cut divide between the services of a medical practitioner like physicians, psychiatrists compared to psychologists or clinical psychologists. The patients seeking psychiatric intervention in government hospitals are way too high, and people have been taking pill for their problems. The psychologists are not equipped or trained in psychopharmacology to discuss the treatment plan involving psychotropic categories with other medical professionals, including psychiatrists. In my last 26 years of practice, I always felt that in spite of my various therapies, there was something lacking in my way of understanding my patient's problem holistically. I was applying psychosocial and wellness techniques that worked well with some patients who were, to some extent, able to modify their various faulty ways of coping or lifestyles, but there were many others who were dependent on popping pills and strongly felt that there was no improvement even after prolonged use of medicines. I would like to give an example reported by a family member who disclosed this information while I was taking down notes on family history. No official record is found about this case, as his family had developed fear of doctors after what had happened in their family. The patient was diagnosed with schizophrenia and continued to take lithium for 17 years and died of kidney failure. Another family member from the next generation who was also diagnosed with schizophrenia was again put on lithium for 17 years and he too died of kidney failure. There was yet another recent case of a 49-year-old female who was on antidepressants for almost over 8 years and she jumped off from the 20th floor and ended her life. Names or details are withheld due to the nature of confidentiality. After doing the primer course, the above examples make me question medical professionals. Was the diagnosis correct in the above examples? Was the medication appropriate and was it monitored regularly? And in case 3, was the side effects of medications not given any consideration? Ordinarily, the above cited cases can't raise questions in the mind of psychologists in India about the relevance of psychotropic medications because they are not directly involved or trained to think on those lines, and therefore, for me too, it only mattered to the extent that the patients were sent for any review of medication to a psychiatrist, as they are the ones who are trained to monitor medications in my country. But 5 years back, my perspective changed when I found out about the pioneering work done by prescribing psychologist Dr. Elaine Levine, and her great contribution towards serving the rural and urban less privileged in the state of New Mexico, United States of America, the first state to pass state laws for the prescriptive authority to prescribing psychologists. The psychobiosocial model of care, developed by Dr. Elaine Levine and Dr. Elaine Foster, appeared to be a holistic approach towards the treatment of mental illness. Inspired by Dr. Levine's work, I requested her whether it was possible to extend the psychopharmacology program to India, as there was a huge gap between doctors and patients. And I thought that training in psychopharmacology would equip psychologists in India to support the psychiatrists or other medical professionals and thus reduce the gap, monitor or review or even collaborate with them on the treatment plan and thus assist them in the treatment of the patients. Dr. Levine guided me to do a pilot study on the attitude of the medical professionals, whether they were open to this model of care. Interestingly, the survey results showed that specialized medical professions like cardiologists, surgeons, pediatricians, and psychologists were very open to the model, but physicians showed resistance. According to India's Health Ministry, 6% to 7% of the population suffers from psychosocial disabilities, and there is a shortage of health professionals to meet the demand for care. India has 3,500 psychiatrists, one for every 3,43,000 people according to the WHO, whereas in the US there is one for every 12,837 people, quote close. Further, in an epidemiological study carried out in a rural population in Tamil Nadu, southern India, it was reported that about 75% of people with mental disorders had been sick for more than 1 year and had not had any treatment. With training and knowledge in psychotropic medication, psychologists and counselors can be a part of a task force who can reach out to people in the communities and understand the use of over-medication, which may cause new psychological problems in addition to primary conditions. I am convinced that the training of psychologists or even registered nurses in psychopharmacology can be of immense use both in the rural as well as urban India. I have gained a lot from the RXP International course. In fact, after completing primer psychopharmacology, I saw an immediate shift in my approach in my intervention towards my patients. I felt empowered and at the same time felt more responsible towards my role as a psychologist. I also found the algorithm for treatment from a psychobiosocial framework very useful, and it has helped me modify my interview notes with patients or jotting down the background history of patients in details with greater accuracy. I have started reviewing the prescription given by psychiatrists and physicians or even neurologists carefully, and I've started to participate with confidence in giving my input in discussion while collaborating with psychiatrists and physicians. In conclusion, with an open mind, I feel the time is right for all mental health practitioners to join hands to gain that extra knowledge that could play a significant role in the treatment of mental illness. The time is now for psychologists to work in uniformity on the front lines for global well-being. Thank you so much for your patient hearing.